Hi everyone. This week we're going to learn more about cancer management of the esophagus and the stomach. A few facts and figures on esophageal cancer. It is 3 to 4 times more common among men than women. The average age of a patient diagnosed with esophageal cancer is 68 years old. Overall, the rates of esophageal cancer in the United States has been fairly stable, but falling on an average of 1% each year over the last 10 years. It was once more common in African Americans, but it is now equally as common since the rates for African Americans has fallen and the rate has gone up slightly in whites over the past few decades. This cancer represents only 1% of all newly diagnosed cancers in the United States, but it is much more common in other parts of the world. The 5-year relative survival rate have improved due to improved treatment. In the 60s and 70s, relative survival rate was only 5%. Currently, the relative survival rate is 19%. Doesn't seem like a big increase, but it is huge. A reminder that the layers of the walls are the same for the esophagus all the way to the anal canal as illustrated here. It is important to know these layers since this is once again how the tumor, is assigned a stage for these cancers. Esophageal cancer begins in the inner layer of the wall and grows outward. This is what the layers of an esophagus looks like under the microscope, just for a more real-life illustration. This is an illustration of the different sections or subsections of the esophagus with the estimated length in centimeters. They give you the centimeters because when the physician does an upper endoscopy, they will use centimeters as landmarks when they're looking at the esophagus because everyone's esophagus isn't exactly the same. So they kind of determine the different sections of an individual's esophagus by how long it is in each portion. When assigning the primary site code when abstracting, the codes are basically the cervical, upper third, middle third, and lower third of the esophagus with C15 codes. The esophageal gastric junction, EG junction, or also known as the EGJ, is actually considered part of the stomach, which is why it has a C16.0 code here. However, a primary C16.0 can be staged using the stomach or the esophagus schema, depending on the tumor's epicenter into the proximal stomach and whether the EGJ is involved. Don't worry, you don't need to, remember that. However, we will talk a little bit more about this when we discuss the site-specific data items for the esophagus and stomach. There are no screening tests to look for cancer of the esophagus in people without symptoms. People with Barrett's esophagus may be advised to have regular endoscopic examinations since this is considered a precancerous condition predominantly seen in people with long-standing acid reflux. Signs and symptoms may include the listed conditions on this slide. Diagnostic tests for esophageal cancer may include a barium swallow, where the patient swallows a liquid that coats the esophagus, and x-rays are then taken to determine any abnormal looking areas or blockage of the esophagus. An upper endoscopy, also called EGD, uses a flexible tube with a light and camera to look at the lining of the esophagus. If an abnormal area is identified, then a biopsy will be performed. An endoscopic ultrasound may be performed at the time of an EGD or sometimes it's done afterward. An endoscopic ultrasound is used to identify how far the tumor invades the esophageal wall and if there are any abnormal looking lymph nodes near the tumor. A biopsy of the lymph nodes are usually performed at this time to verify that the nodes are positive or negative with cancer, because this will determine the treatment plan for the patient. All right, the illustration here shows what it looks like when the doctor does the ultrasound. See how they can see the different layers of the esophagus. And if there's a tumor, then that would be interrupted. So that is a normal endoscopic ultrasound, or EUS. A CT and or a PET scan will be used to determine if there is metastatic disease. Once again, this information is used to determine the patient's treatment plan. An MRI may be performed to determine the tumor involvement of the esophageal wall, but this can usually be determined by the endoscopic ultrasound. There are two major types of esophageal cancer. Squamous cell carcinoma, which usually develops in the upper and middle part of the esophagus, and adenocarcinoma begins in the glandular tissue in the lower part of the esophagus. You might want to make a note of that. Squamous cell carcinoma usually develops in the upper and middle part of the esophagus. Adenocarcinoma begins in the lower part of the esophagus. Rare tumors, which make up less than 1% of all esophageal cancers, include neuroendocrine, lymphoma, and sarcoma. For early stage cancer with the tumor confined to the wall and not through the esophageal wall with negative lymph nodes, surgery is the optimal treatment for longer survival. Depending on the pathologic extent of disease, the patient may have to undergo or will be recommended to receive adjuvant chemotherapy. For cancers that have spread beyond the wall with or without positive lymph nodes, the following treatment is recommended. And the treatment is a little different depending on that histologic type of cancer. For squamous cell carcinoma, chemoradiation with possible surgery after is usually recommended depending on how well the chemo and radiation worked on the tumor. So the patient will get the chemoradiation, they'll do a CT scan to see how well the tumor responded to that treatment, and then decide whether the patient can go on to have surgery or not. For adenocarcinoma, chemoradiation with surgery is recommended unless the patient has other risk factors that would deem them non-operable, such as comorbidities or their age. For early localized esophageal cancer, tumors that only invade the lamina propria or submucosa are sometimes treated with a less invasive procedure called endoscopic mucosal resection. You'll also see this abbreviated as EMR. There are many different methods of endoscopic mucosal resection. This less invasive technique should only be attempted, though, in patients without nodal or distant mets. Tumors are slightly raised but need to be less than 2 centimeters, or the tumor is ulcerated and less than 1 centimeter in size. So for a physician to use this treatment technique, the cancer must be caught very, very early. This illustration demonstrates the technique that uses a saline injection. The lesion borders are marked with a coagulator. Highly concentrated saline and epinephrine are injected into the submucosal layer to swell the area containing the lesion and the markings that were made. The mucosa outside the marked border is excised using a high-frequency scalpel to the depth of the submucosal layer. The resected mucosa is lifted and grasped with forceps, trapping the lesion with the snare and then resected by electrocautery. So that's a less invasive procedure. However, once again, it must be done, the cancer must be found at a very, very early stage. However, when the cancer is not caught early, invasive surgeries must be used when appropriate. These surgeries include partial esophagectomy with a portion of the esophagus removed, total esophagectomy with the entire esophagus removed, esophagectomy with laryngectomy, where they remove the entire esophagus but also remove the larynx, and then esophagectomy with a partial gastrectomy or a total gastrectomy. They take the esophagus and either part of the stomach or the entire stomach is also removed. There are two site-specific data items to collect for esophagus. So to determine whether the case should be staged using the esophageal or the stomach schema, we have to answer the question, is the esophagus or EGJ involved, and how close is the epicenter of the tumor to the proximal stomach? This illustration gives several examples of how the tumor epicenter is determined and whether the tumor would be staged using the esophageal or the stomach schema. For an EGJ tumor with its epicenter located greater than 2 centimeters into the proximal stomach, or if a tumor is involving the cardia but not involving the EGJ, both of these would be staged as stomach cancers. Tumors involving the EGJ with their epicenter less than 2 centimeters into the proximal stomach are staged as esophageal cancers. The second site-specific data item is the location of the tumor. Is the tumor in the upper, middle, or lower esophagus, which the lower esophagus does include the EGJ. Now on to stomach. Stomach mostly affects older people, just like esophageal cancer does, with the average age at diagnosis being 69 years old. This cancer is much more common in other parts of the world, particularly in less developed countries. Death rates have been falling over the last 10 years, but the 5-year relative survival rate is still only 31%. Until the late 1930s, stomach cancer was the leading cause of cancer death in the United States. Reasons for this decline are not completely known, but may be linked to the increased use of refrigeration for food storage. This made fresh fruits and vegetables more available and decreased the use of salted and smoked foods. Some doctors think that the decline may also be linked to the frequent use of antibiotics to treat infection. Antibiotics can kill the bacteria called H. pylori, which is thought to be a major cause of stomach cancer. This illustration demonstrates the different parts of the stomach. So it's a good visual for the sections and the layers. Here's an illustration denoting the ICD-10 sub-site codes for the stomach. This is what the layers of the stomach wall look like. The layers are the same as the rest of the GI tract, just like I said earlier, but the mucosa is a little different looking with the added elements of the gastric pit and gastric gland. The T of the AJCC TNAM staging for the stomach is once again determined by the invasion or the depth of the invasion of the 4 layers of the stomach wall. Signs and symptoms for stomach cancer may include any of these listed here. Diagnostic tests for stomach cancer are the same as with the esophageal cancer. I've got an illustration here, which is a barium swallow study, and it's outlining the stomach, but it's demonstrating an apple core appearance in the middle, and that's identified with these arrows. In the middle part of the stomach, which is highly suspicious indication of a stomach cancer. So that's kind of what the barium swallow looks like for stomach cancer. The most common type of stomach cancer is adenocarcinoma. Other rare types include lymphoma, sarcoma, and carcinoid. The top pathology photo is an early stage adenocarcinoma, and the other photo is actually an extranodal marginal zone lymphoma of the stomach. So lymphomas, once again, can be found in other organs than the lymph nodes. That's what it looks like. Treatment for stomach cancer includes surgery, but only for early stage tumors that only invade into the submucosa and the nodes are clinically negative. A patient may need chemoradiation after having surgery depending on the pathologic staging or pathologic findings. If the tumor invades the muscularis propria with negative or positive lymph nodes, treatment would include neoadjuvant chemotherapy or chemoradiation. And therapy may include immunotherapy as well. If a patient is found to have stage 4 disease, palliation is normally recommended. Most often, a combination of treatment is offered to patients since it is difficult to cure stomach cancer, especially since it is often not found until it is at an advanced stage. Here's a listing of surgeries that you may have to code when you abstract a stomach case if the patient has surgery. Unfortunately, in my experience, surgery is not done very often. The only site-specific data item that is collected for the stomach is once again that information that determines whether the tumor is going to be staged using the esophagus or the stomach. So that's the only site-specific data item for the stomach. Let's quickly just review NCCN guidelines. All right, so you will notice we won't review the esophageal guidelines, but you'll see here that the esophagus and the esophageal gastric, the EGJ, are included in the same guidelines. So they are together, all right? Now, if you go down and you want to find stomach, you'll notice that stomach isn't down here. So what's another term for stomach? Gastric. So the stomach is listed under gastric. All right. So one thing that I don't think I've discussed in the past about the NCCN guidelines is not only do they explain, the pathways for patients to be diagnosed, their workup and treatment and things, but they also give really good principles of, endoscopic staging, surgery, systemic therapy, radiation. So if there's anything in the guidelines that, you don't really understand what they are talking about, usually there's a link either within the guideline itself or at the bottom of the page where you can click on these different principles. And as you can see, if you click on one, it just explains, what should be done and how and things like that. So this is a really good way to kind of learn about the different procedures and treatment for a specific, type of cancer. So, whenever you need something to read, there you go. You can learn about the principles. It just gives you a better understanding of, why things are the way they are. So, for the stomach, just click on workup. And as you can see, the workup is pretty extensive. You need to do the upper GI endoscopy with biopsy, chest CT, possibly a PET CT, lab work, and then the ever important endoscopic ultrasound. Okay, because that's really going to drive, what the treatment is. So it's a very important procedure to do. And then it's broken down. This clinical stage is either in situ or a T1A or local regional. That's all lumped together with no distant metastatic disease. And then stage 4. As you can see here, if someone is stage 4, just like we stated earlier in the presentation, the management of that patient is going to be palliative care. All right. Then when it comes to breaking down these different stages, the very early stages or local regional, what needs to be determined is whether the patient is medically fit or if they're not a surgical candidate, because that's going to lead the way. And that doesn't matter, which stage it is. If it's local regional, and once you determine that, whether they're physically fit or not, you should consider a laparoscopy with cytology. So the laparoscopy is just when, they cut a couple little holes in the patient's abdomen while they're under anesthetic, and they view the abdomen, check to see if the fluid in the abdomen is positive for cancer, or if there is possibly tumor implants around the abdomen that did not show up in on the PET CT scan, because then that would make the patient a stage 4. And then, if that happens, then the treatment would no longer be, treatment. It would be palliative care. All right. So that's kind of why they do that. It's a very, it's non-invasive way to, really verify the stage of the patient. So then, and multidisciplinary review is preferred. It's very important that these patients have, all the different physicians get together and discuss the treatment plan for these patients. So then, once again, you have your very early stage. If they're a non-surgical candidate, then the ER, the endoscopic resection, okay, is going to be preferred, okay, because they can't undergo a major surgery. So they would do that endoscopic mucosal resection. If they are medically fit, they could either do the resection or go on to surgery. All right, and just, if they're fit enough, have that big surgery, because that surgery is going to be the best outcome for that patient. All right. For the local regional disease, medically fit, then if they are medically fit and their cancer is potentially resectable, a CT1B would go directly to surgery. All right. T2 or higher with or without positive lymph nodes could either have surgery or perioperative chemotherapy, which I have not seen in my experience, but I'm sure the bigger institutions do probably offer that, or preoperative chemoradiation. And then if the patient, once they finish that, then they would click on C response assessment. And after they go through that treatment, then they're going to have a CT scan with contrast, because the physician needs to know how well the tumor responded to that treatment. If the treatment is now resectable, they can go for surgery, or if, they can be offered just palliative management, just to be observed, okay? If the patient is resectable or their cancer has progressed to distant metastatic disease, then they would go to palliative management, okay? So let's go back a couple here. So if the patient did go to surgery, okay, you could click on surgery, and then what they do is the R1, or I should say R0, R1, and R2. The R0 is when no cancer is at the resected margin, okay? So when the surgeon removed the stomach, the margins are negative. That would be an R0 resection. If the margins are microscopic, they're positive only by looking under the microscope, then you would have a R1 resection. And R2 resection is when the surgeon, when they did the surgery, he couldn't get negative margins. He had to leave some cancer behind, and he could see that with his naked eye, so that's called macroscopic residual cancer. All right. So, if you have negative resection margins and the tumor ended up being in situ in a pathologic T1 and 0, no nodes were positive, the patient would go to surveillance. If they had a T2 tumor with negative lymph nodes, they could do surveillance or chemotherapy. If it's a T3, T4, whether positive lymph nodes or not, and then any T with positive lymph nodes, the patient could have chemotherapy using different chemo regimens, okay? And then once they do that, you would click to follow up, and then that's how the patient would be followed. They would need to undergo, these types of things every so often, okay? So that's just a quick review, once again, for NCCN guidelines, just to get you to understand a little bit more, what the standard of care is for a certain cancer, and how the physicians decide how they decide what treatment is, appropriate for the patient. So, as with previous presentations, you do not have to memorize the facts and figures or the site-specific data items. For this week, you do not have to memorize the surgical procedures for either of the primary sites. Okay, that's not really the important part of this information, because it really doesn't happen a whole lot. Just make sure you know the other information within the presentation, and make sure that you know the information within the assignment well, all right? That's what you'll be, quizzed on in the future. If you have any questions, please post them in my virtual office. And until next time, have a great week, everyone.